kind of help guide the evening here. If you need the restrooms, they're right out these doors and right out front. We will be ending the evening with a question and answer session. If you have any questions related to women's health or anything pressing in general you'd like to ask, you have notepads on your tables and pens. You can write those questions on your notepad, and Genesis is sitting in the back of the room. You can funnel your question back to her. Feel free to walk that back, and she's got a way to connect that up to me. We also had the raffle at the front. If you didn't get your ticket for that raffle, please fill it out and give it also back to Genesis in the back here. We'll draw that prize at the end of the evening. The basket is courtesy of Generation Senior Living. They're located in Strongsville and Berea, and they provide independent senior living. All of our refreshments are from Riverview Point. They're in Olmsted Falls. They provide skilled nursing care, rehabilitation, and long-term memory care. Please feel free to get refreshments throughout the evening. Just be courteous to those around you and to our panel. I'm going to hand off now to Lori Fahler. She's our Community Outreach Nurse Coordinator, and she'll introduce our panel tonight.
Hi, everybody. I'm Lori Fahler. Most of you I know. Those of you that don't, I am our Community Nurse Coordinator. I plan all of the programs. On the table in front of you is a schedule of all of our events for April and May. If you gave me an email, I will add you to the email list so you'll always know what's going on. There's also an evaluation form. If you could fill that out by the end and hand those back to me at the end of the evening. I pay really close attention to what type of programming you want so that we're providing what's going to be helpful to you. Who is with us this evening? Jill Bartell is the clinical manager of our Cosgrove Maternity Center. She'll tell you a little bit about that. Next to her is one of our lactation consultants. That's Darlene McDivitt. Lisa Wolanin is a physical therapist here at LifeWorks. She is specializes in pelvic floor therapy. And this is Dr. Emily Lasota, one of our OBGYNs. I'm going to have them briefly introduce themselves, and then Emily is going to give a real brief talk, and then we'll open it up to questions and answers. I tried to be brief so we could get started with you guys.
Hi, everyone. My name is Jillian Bartel, Clinical Manager of Cosgrove Maternity. So we are really excited. 9 months ago, we opened our brand new state-of-the-art facility. We did increase our level of service to a level 2 maternity and special care nursery, which is really exciting. We are able to provide higher level of care to our patients. We're able to deliver 32 weeks and above, take care of higher risk moms, keep a little bit of sicker babies in our special care. We take pride really in our new environment. We're really excited to work in it. It's very calming. It's just a very nice, caring environment that our nursing staff and our OB/GYNs and neonatal nurse practitioners are able to provide care in our department. We're really excited, so please send everyone our way. We are hoping to ramp up this summer and deliver a lot of babies. All of our nurses are very highly trained, very experienced, and we love to be part of a good birthday party. So come and join us.
Yeah, that's a good. Hi, my name's Darlene McDivitt. I do the lactation program helping moms with breastfeeding at Southwest. I have a partner in charge with me. We do what we call birth journey phone calls. So anybody that's contemplating having a baby, coming to maybe Southwest or shopping around for a hospital, they can call our birth journey line. There's pamphlets in the back, and they can talk to us, and we can direct them, give them information that they need, or set up a time to talk to them about what's going to happen when they come into the hospital. So it's a general line. And then we offer some prenatal classes. We're going to be starting here in-person newborn and grandparents class. So any of those grandparents, we're going to be doing grandparents class. Also, we do those online now. We have childbirth. We have a daddy boot camp. So for dads, there's a class that we have Randy and Mike do, and they do awesome with it. And it's just helping new dads get ready for, being a dad, and what they can do to support their partner and help take care of the baby. So, but if anybody has any questions about our classes or programs, let us know.
Hi and welcome. My name is Lisa Wolanin, and I am a physical therapist and clinical specialist over in the LifeWorks building. And we started our pelvic floor program about 11, 12 years ago, based on demand. And we started off with 2 of us, and it's grown to 6 of us, and we cover lifespan, pregnancy, postpartum, pelvic pain, incontinence, all kinds of urinary issues. And the program has really grown. We started off a patient here and there, and now they're, beating the doors down. Once you help one person, it kind of has a snowball effect. And once the doctors kind of get to know, what we're able to offer their patients, it really grows as well. So we're real pleased to have our new therapists on board in our other facilities, and we're here to help men as well as women now. Thank you.
Hi, I'm Emily Lasota. I'm an OBGYN at Southwest. Before I get started, let's just give Lori a round of applause for setting this up. Thank you so much, Lori. She works really hard. And I just want to thank all of these women that are here with me, because when we take care of people, it is a team effort. So there's nothing, taking care of people, I could not do this by myself. I don't even do most of the work. It's them that are doing most of the work. I just kind of figure out the problem. That's true. Yeah. So Jill's in charge of all the nurses. Darlene helps with, just anything that needs, we have a crash C-section. Darlene's there. She's like, I'll scrub the C-section with you. Someone has a problem breastfeeding. Someone doesn't know. She's there. Darlene can do it all. And then Lisa, oh my gosh, she takes care of so many people. She probably takes care of people in their teens, 20s to their 80s. She does such a good job, and she takes the time that I don't have in the office. So all these women are fantastic. Give them a round of applause too. Okay, great. And I'm being nice to them so they make my job easier. No. Okay, so I didn't know kind of what the crowd was going to be tonight. I didn't know if it was going to be teenagers, people in their 20s, people in their 50s. We have a range, mostly young women here tonight. I see a lot of young women probably going to have babies, so we'll talk a little bit about that. And then some women that are done having babies, some women that are after menopause. So we'll kind of go over everything. I got a general handout here of just why to see an OBGYN. So Lori asked me to talk for 15 minutes. I don't know if I'm going to hit the 15-minute mark, but I'm just going to kind of go over what an OBGYN can offer you. And some of you probably know what an OBGYN can offer you. Some of you might be surprised at what what is listed here and what can be discussed. But use this information for yourself. Use this information if you have daughters, sisters, anyone that you know. Just because I feel like OBGYNs are someone that people will go see for, they have to go to get birth control or problems with their periods, and we can hit a lot of other things that you weren't intending to hit at those visits to kind of take care of the entire a woman. Primary care doctors or PCPs, they can hit a lot of this stuff too, but a lot of times people put off those appointments, but people don't put off going to the OB. And we know you in a very intimate sense, whether it's knowing personal details of your life or doing intimate exams. So it's easy to open up to someone, and someone that you don't have to have barriers with when you're talking about personal issues. Okay, so this is kind of organized. It's not organized in a chronologic order. It's more organized by, alphabetical. So I'll just kind of go over a few things, and I might expand on a few things that some of you guys might be interested in. Obviously, if you have specific questions, you can ask it at the end. But this is just what I do on a daily basis, and I hit everything on this list. I found this on the ACOG website. So ACOG is American College of OBGYNs. I found this, and it really hit on everything that I did. I didn't even realize I did some of this, and I was like, oh yeah, I do that. So I'm glad I had this base to go off of. Okay, so birth control. That's obviously easy. That's probably why a lot of you guys saw an OBGYN for the first time, because you said, I don't want to get pregnant right now. Especially with abortion laws changing and it not being an option or as easy of an option, birth control and family planning is extremely important. So, and I'll say a lot of this stuff here is preventative. It's not treating a problem, it's preventing. And our healthcare system and our country in general doesn't focus as much on prevention as it should. But women tend to be, into prevention, especially if we're encouraging it. So birth control, preventing an unintended pregnancy and planning for an intended pregnancy. So we manage birth controls from pills, which are one of the most common birth controls, to patches, to vaginal rings, to injections, arm implants, and IUDs. So we do that in the office every single day, and I could talk to you with my eyes closed, in the middle of my sleep and give you the whole spiel about that. So if you have questions about birth control, please ask at the end of this. Okay, so cancer screening. So what cancers do we screen for? So breast cancer, that's a big one. Clinical breast exams are very important, but they are no substitute for mammograms. So a lot of women say, I don't want to go get a mammogram because you have to squeeze my breast and it hurts. It's 10 seconds. You can do it. Breast cancer is something that we can catch very early and is very treatable. So we'll do a breast exam, but get mammograms recommended to start at age 40. Cervical cancer. So cervical cancer in this country is not too common, which is a good thing because pap smears can catch cervical cancer so early. So cervical cancer guidelines, screening guidelines recommend starting at age 21 and going through 65 if your pap smears are normal, those last 10 years. If your pap smears are abnormal, you may have to go past 65. Pap smears and pelvic exams are different. A pelvic exam is looking in the vagina, feeling the uterus and ovaries. A pap smear is actually collecting the cells from the cervix. It's named after some Greek scientist, Papanikolaou, and that's how I always tell people that because you can't forget that name. But he invented pap smears. I think he did a pap smear on his wife every day for multiple years and used it to learn about. I know, what a wife. But if you look up in how pap smears were invented, it's quite interesting. But so pelvic exams are important to get through the duration of your life. Usually, pap smears can stop at 65. Let's see, other cancers of the reproductive system, that would include ovaries, uterus, and that's usually caught based on history and a physical exam. So genetic testing. So one kind of newer thing that is going on in medicine is using your genetics to assess your risk of cancer. And a lot of women will have breast cancer, 1 in 8. So most of us will know someone in our family who had breast cancer. The important thing is if there is a trend in your family, we need to pick up on that and say, 2 first-degree relatives or 3 people in your family had cancer or someone before a certain age. Maybe there's a genetic reason for that. Maybe we should test you. And if we test you and you're positive for something, we can catch it sooner. We can test you sooner. And if you're negative, it can give you a little peace of mind, okay? So getting genetic testing for yourself to assess your cancer risk is something that's really important. And I think it's underutilized in medicine. I think we should use it more. Am I okay on time? Okay. Let's see. Health maintenance. What'd you say? Okay. Health maintenance. Blood pressure, diabetes screening, osteoporosis. That's important to get blood pressure screening. You get that with us, with your PCP, really any doctor's visit. And why is blood pressure so important? It's a vital sign. Vital means the most important. So more women, I believe, die of heart disease than any other cause in this country. And blood pressure, high blood pressure, poorly controlled blood pressure, uncontrolled diabetes, those contribute to that. So heart disease prevention starts at screening at the most basic level, okay? Osteoporosis, that is usually something we start screening for at age 65. You can start sooner if you have risk factors for osteoporosis. And I can't say specifically for each person what your screening, starting point should be because it's so specific to every person. So these are guidelines, but again, it's a one-on-one decision with your doctor. Healthy weight, that again is another thing. We'll take your weight every time. Take your shoes off. Don't hold your purse. Get an accurate weight on the scale. But don't say oh, I'm going to skip my weight today. Let's just keep a track of it. Okay, let's just document it and then we'll address it. Okay. Infertility counseling. So I see a lot of patients for infertility. That's becoming a lot more common nowadays as women put off having kids because of financial burdens, wanting to advance their career. So this is becoming more common. I think the estimate, again, is 1 in 8 women, but I think it's probably higher. So we talk about that, how to prevent it, the initial workup. We prescribe some infertility treatments, so that's something that we can do. And I know this list is probably going all over the place, but that's how I feel my job is. I feel like I'm taking care of a 13-year-old, middle schooler, and then I'm taking care of a great grandma, and then I'm taking care of a pregnant woman, and then a menopausal woman at around 50. But that's our job. We kind of are used to following you through all the stages in your life. Mental health screening, so anxiety, depression, other things like that. You can talk to your PCP, you can talk to us, you can talk to a mental health counselor about it, but those issues are very private. Sometimes you just want to start the conversation with your OBGYN, someone that's delivered your babies and knows you very intimately. And it's not, it's nothing that we judge for. It's nothing that will change your relationship with us. Just be honest with us. We'll use that to treat you. Menopause care. So menopause is basically the cessation or stopping having periods for about 1 year. After 1 year, you are postmenopausal. The average age is about 50 to 51 in this country. Some women have a hysterectomy, so it makes it a little bit harder to figure out when they go through menopause. It must be nice to not have any more periods. But with menopause, the stopping of the periods is the good thing. With it comes a lot of other things that are a little bit more unwanted. Hot flashes, changes in your bowels, changes in your skin, changes in your weight. So that's something that we talk about all the time too. Menstrual concerns. So as women, we are lucky to get periods. We start, some women start younger than 10. Most women start, around 12. And then for the next 40 years, we get periods. Periods should not control our lives. And coming to the OBGYN is a very good way to say, I have my period. I might use my uterus one day, so I guess I'll keep it. But until I use it, how can I make sure my life doesn't revolve around bleeding? So our goal is to help make sure that you don't become anemic because of bleeding, that you're not bedridden because you're having such bad pain. So talking about those things, women a lot of times have been taught to, suck it up, just do your job, don't complain. And the things women go through, women will bleed to the point of anemia because they were taught, well, it's just my period and I have to put up with it. Don't just put up with it. Come talk to us. We will make it better. Pregnancy care, we do all prenatal care from the minute you have that positive pregnancy test to delivery. We have, in Southwest General Medical Group, we have 9 doctors, and then there are 3 independent doctors as well, Dr. Kraus, Dr. Cardona, and Dr. Jingo. So we have, how many would that be? 12 delivering doctors. We always have a staff in the hospital 24/7. Tonight it's Dr. O'Neill over there delivering babies. One of my patients is in labor. She's helping her out. But we're all fantastic. I would never trust patients or put patients in the hands of doctors I didn't trust. I delivered there 3.5, 4 years ago, and Dr. Dubchuk was my doctor. So everyone is just fantastic. And I'm the least experienced of them anyway. I'm the youngest, so you don't even want me. You want one of them. Okay. I don't know what I'm talking. No, I'm just kidding. Okay, let's see. Pre-pregnancy counseling. So that's, again, just talking about how to get pregnant, what to do before pregnancy, how to optimize health during pregnancy. And I'm still good on time. Okay, I'm wrapping it up. Okay. Sexuality and healthy relationships. If you're having uncomfortable sex or loss of sex drive and that's a problem, please bring it up. If you want to have a sex life and it is uncomfortable, don't say, well, I'm just going to put up with it. Don't have that mindset. The mindset is, I want it to be better. How can I make it better? STD or STI infections, again, catching things early, treating things early, super important. And that can be if you have sex with anybody without a condom, there is a risk of that. And I don't care if you're 17 or 57. So come see me. We'll do it. And there's no stigma. We'll just test you. Urinary incontinence, something that Lisa's probably going to talk about, very common in women, especially women who have vaginal deliveries, multiple vaginal deliveries, 9-pound babies. Women come to me all the time, well, I've been dealing with it for 10 years. Don't. Come talk to us, please. And then vaccinations, we do flu vaccinations, but the big one is HPV vaccinations, which are typically done in teenagers and patients in their 20s. HPV is the #1 cause of cervical cancer, so if we can vaccinate our younger generations against HPV, we can almost all but eliminate cervical cancer. Sorry I talked for so long. Thank you. Yes.
Well, thank you so much. I think that was super informative and hopefully answered some questions before we even had to ask them. I know we had some issues with our Facebook Live, but I'm getting a lot of questions in the comments from folks, even though they can't be here today. So I'm going to read off some of those and give you all a chance. Feel free, if you want to speak up, raise your hand. I should be able to hear you, but if you would like to submit a question without being put on the spot, again, you can write them down and give them to Genesis. So we'll just go ahead and get started, and whichever panelist wants to jump in with the answers, please feel free to jump in. One of the first questions in the comments is, what are the levels of NICU and what level is Southwest?
I will answer that. So we are a level 2. So the levels are level 1, which we were previously. Level 1 is low risk. Level 2 is right in between, and then level 3 is high risk. So your Fairview, University Hospital, those are level 3s.
Okay. This question, I delivered in April 2020 at Southwest. Are there any updates to the facility? I will be visiting again this year.
Oh, totally.
I'll take that one again. Yes, definitely. We completely expanded our entire beautiful unit. We doubled our space. Our birthing suites are giant. There is tons of space for our patients to walk around and really stay active during their labor. Our operating rooms are state-of-the-art, giant delivering rooms. Postpartum has been updated as well. Anything else? Yeah, I think that's pretty much it.
Okay. What is the lowest hormone birth control? This person says, Loestra and Effie made me ill. All 6 months I tried to take it, and I'm not interested in an IUD.
So birth controls can have hormones or no hormones. So the only no hormone options would be condoms or an IUD with copper. So those have 0 hormones. The copper IUD typically lets periods maintain how long and heavy they are, but it can make it a little bit heavier. So you do trade no hormones with kind of some changes in your periods. When it comes to hormonal birth controls, so in terms of pills can have estrogen and progesterone or just progesterone. So low estrogen is the lowest estrogen option. There is a no estrogen option. So a progesterone-only pill called Slind would technically be no estrogen option. The birth control patch and the NuvaRing both have estrogen and progesterone. So if this patient had complications or side effects from estrogen, I probably would not suggest that. Depo-Provera is an injection with progesterone only. That is every 3 months. It's an IM injection, intramuscular, so some people don't like needles, so I wouldn't suggest that. But it's a nice option without estrogen. The arm implant is progesterone only. It's the Nexplanon. It's good for 3 years. And then the progesterone IUDs, there is Kyleena, which is good for 5, and Mirena, which is good for 8. I think a huge misperception is that IUDs are dangerous and can't be put in women who've never had kids before. I think IUDs are some of the best inventions ever. And public service announcement, don't take your medical advice from social media and TikTok. But I have had so many people come and say, well, I saw on TikTok, I can't get an IUD because of X, Y, and Z. Talk to us, please. We'll go over things. But an IUD is not your only option. There's other options. But again, I apologize if you were born with a uterus. Sometimes it creates some dilemmas, but we'll figure out something that works for you. We will. But it can be a little bit of a trial and error finding what can you use for pregnancy prevention that you also are happy with your bleeding pattern and minimizes side effects.
Thank you so much. I'm not sure if this question is specifically related to pregnancy. This is coming from the person who's asking a lot about the NICU. We don't hear as much about COVID. Should we still be worried?
Why are you passing it to me?
Maybe can we talk about what COVID restrictions look like in the nursery?
Sure. So, well, in general, we do, we lifted our COVID restrictions for visitors, but we still do have a limited visitor policy for all of our patients. We are a locked unit, so we only allow just a limited visitor, designated visitors, and everyone is screened health-wise when they come in. So if you're sick, please do not come and visit our moms and our babies. We do in our special care nursery, which is like a step-down NICU, those are sick babies in there. So we don't want anyone that's ill coming in to visit, but we do limit it to, again, designated visitors for those babies in there, and they do have to come in with mom and support person, whether it's, whoever is with them.
Great. How do I gauge if aches and pains are due to just getting older or if that's something else? Lori, would you maybe, or Dr. Lasota, sure.
Aches and pains, you want me to take that on? Oh geez, that's a very complicated question. I'm not good with joints and bones. I'm not really good with anything outside the uterus, ovaries, cervix.
No.
No. So in general, again, it's very, very specific based on each patient. So I'm going to treat a 20-year-old with aches and pains differently than someone who has other medical problems, a different age, different risk factors. Starting that conversation, again, we make an appointment. We could talk about this for an hour, just on your specific problems, but don't ignore it. I think our big message was, don't ignore it, come talk to us, and just be open and honest, and we'll figure it out. And if we can't figure it out as OBGYNs, which I don't know everything, I refer to a lot of other doctors. I will find the doctor that works for you, and I will send you their way.
I would just add to that too, if it's obviously not something related to an OBGYN, start with your primary care doctor.
Are there any risks later in life if you've gone through menopause early?
Yes. So menopause is considered premature if it occurs before age 40. So that can be cessation of periods before age 40 or removing the ovaries surgically, both ovaries, before age 40. Estrogen, as bad as I think some of us can, make it sound, estrogen. Estrogen is really good. Estrogen helps with bone health in terms of keeping us with healthy bones, heart health, protecting us from heart attacks, mental clarity. It helps help with our metabolism, skin, etc. So essentially, when a woman goes through menopause, she stops ovulating. The cells around an egg in the ovary are what create estrogen. So when you stop ovulating, your ovaries kind of, stop producing estrogen. So low levels of estrogen starting at an early age can put a patient at risk of osteoporosis, heart attack, some other side effects which maybe not be life-threatening, but definitely impact quality of life, causing vaginal dryness, constipation, mental fog, and definitely hot flashes. So if someone goes through menopause before age 40, it's a very important conversation to have about hormone replacement therapy, if that's a good option. And even women who go through menopause in their 40s or even 50s, discussing the risks and benefits of hormone replacement therapy is something to bring up. It is appropriate for some patients, I would say too risky in other patients, but again, that's an individualized conversation to have. No one should ever say all hormone replacement therapy is good or all hormone replacement therapy is bad. So that's, again, individualized.
What are some of the medical reasons women would see a decline in sex drive?
Yeah. So I would say a very common reason couples don't have sex as often is erectile dysfunction. So that would be one cause. But medical reasons for women. So mental health is a big one. So anxiety, depression, stress can affect someone's libido. Unfortunately, some medications that are used to treat anxiety and depression also have a side effect of decreased libido or inability to orgasm or decreased ability to orgasm. But treating mental health is number one. Number two, there's a million. I mean, there's a million. There's a million. Decreased libido there's not always something that we can identify as like what is the underlying cause. Sometimes it is just, it is there and we have to treat it. So treating it with behavioral modifications is a big one. So anything that our brain gets used to, we usually expect or want more, and things that we never do, we don't expect. So just like exercise, getting in the habit's going to make you want to exercise more. I usually recommend scheduling sex, and I know that does not sound romantic, but scheduling sex on a regular basis, maybe once a week, before you get exhausted and you're like, I just want to fall asleep. So scheduling at a time when you're energized, you're ready to do it, making sure you enjoy sex, so communication with a partner. Sex is not just penis and vagina. That does not count as a satisfying sexual activity for most women. So it's having an orgasm, talking to a partner, enjoying it, connecting physically and emotionally. So that's usually my first go-to. Now, this is assuming sex is not painful. Painful sex from vaginal atrophy or other pelvic floor disorders, and I'm going to give Lisa the microphone here, can make someone have a decreased libido, because whose brain is going to want to do an activity when they know it's going to hurt? So there's underlying reasons that can contribute to low libido. It's very hard to tease that out. So again, individualized conversation, but don't be afraid to bring it up. Don't be afraid to say painful sex, orgasm. These are words that just bring it up. Just don't stumble over it. Just say it, bring it up. We'll talk about it. So what can we do for painful sex? I'm going to ask Lisa just to speak on that, at just women of all ages, painful sex.
Okay, that is probably about 50% of the patient clientele that I see is dyspareunia, which is painful intercourse. And just like Dr. Lasota said, sometimes it's a matter of, if it's been painful once, it's going to continue to be painful. And even if we are doing all of the things, and I mean exercise and teaching relaxation and manual therapy, and I tell my patients when they come in, the first thing, the best thing that they did to get rid of their painful intercourse was walk in the door and start that conversation. Because once you start that conversation, you're already showing that you're committed to making this work and having pleasurable intercourse again. And as far as the mental aspect goes, sometimes, my patients are in a positive, nurturing relationship, and they want to be able to have intercourse, but maybe there was something in their past that's kind of reared its ugly head and has caused those muscles to kind of have that memory and remember and not want to respond. Sometimes it's been because of, childbirth or like low estrogen, just different conditions that can cause painful intercourse, tight muscles, frequent UTIs, just so many things that can cause those muscles to be tight and make intercourse painful. But like I said, once it's been painful, those muscles remember and want to revert back to that. So we really have to work on down training. There's an excellent book called Come As You Are by Emily Nagoski, and all of the UH pelvic floor therapists, we meet every other month, and this is our book club book that we're all going to be having read in the next 2 months. And it's an excellent book where it really talks about the non-physical parts of having low libido or painful intercourse, which one of the things that it kind of sticks in my mind that I recently read was context. And the example that it gave was, if your partner is, you're having fun, it's Saturday, you've had a glass of wine, and your partner tickles you, you see that as foreplay, as fun, it's heading somewhere, that you want to be. If you're trying to cook dinner, you're paying the bills, you're helping your kids with your homework, and your partner tickles you, you're angry. Okay, so it's about context too. So there's a lot of other factors that play into that. And so when patients come, and talk to me, it's not just always what exercises are we going to do, what kind of modalities can I use, but we'll talk about those things as well, and how we can get past some of these obstacles.
Awesome. While you have the mic, we have a couple other questions I think that you could answer. Do you need a referral for pelvic floor therapy for urinary incontinence?
Well, that's kind of a loaded question. As a PT here in Ohio, we have direct access. So that means I have my own national provider number, and I do not need a referral. Certain insurance companies, including Medicare, do require that. So for incontinence, if it's not Medicare, I usually do not require a referral. If it's pelvic pain, I usually like to have a referral. And again, that's just me personally, because I want to know that I wasn't the first person to do an internal exam on this patient. If it's been years, I really like to know that they've seen their OB or that they've seen their general practitioner, and that that everything is okay, and that a lot of things have been ruled out before they come to me. But for urinary incontinence, usually I don't require that as long as it's not Medicare.
And how long do you need to see someone for urinary incontinence before you see a difference?
Well, there are different kinds of urinary incontinence. There's the stress incontinence, which are those little tiny leaks that happen when you cough or sneeze or jump. And then there's urge incontinence. Those are those larger leaks that occur, where you don't make it to the bathroom or you stand up and it just leaks. There's mixed incontinence, which are a combination. That's actually a majority of my incontinence patients have little symptoms of both. So it really depends on the type of incontinence. When you're dealing with weakness of the pelvic floor, it's just like any other muscle in your body. It's going to take some time to strengthen that and to strengthen the muscles, not just the pelvic floor muscles, but the muscles that are the foundation and support the pelvic floor. If it's urge incontinence, where it's more of faulty habits, and a lot of times work and life situations kind of get in the way and sabotage our efforts to maintain our continence. And if it's, poor habits, sometimes that stuff turns around pretty quick. And within a couple of visits, I usually see my patients once a week. So usually within those first 2 or 3 weeks, we're seeing some improvement, even with the stress incontinence, once we teach patients how to change some of these habits that are going to help them be more successful.
Awesome. How do you test for ovarian cancer?
So I would say that our knowledge on how to screen for ovarian cancer is below where it should be. And that has to do with the nature of the cancer and the funding for research into ovarian cancer. I think assessing risk for ovarian cancer is kind of where we start. So risk factors for ovarian cancer include family history, and in general, the lifetime risk of ovarian cancer is 1.7% in women. Family history is a strong indicator, but most women who get ovarian cancer have no family history. The pelvis, fortunately or unfortunately, is very accommodating of large masses, aka uteruses in pregnancies. So the pelvis can hide a large mass for a while before it becomes evident. Sometimes, and I would say this doesn't happen often, but you can catch ovarian cancer early by just doing an exam, feeling a mass in the ovary. If something feels unusual on your exam, we get an ultrasound and follow that up. Unfortunately, sometimes masses can grow rather large before we can feel them, especially if they're filled with fluid, because it can feel very similar to bowels. Ultrasounds are usually the best way to look at a uterus and ovaries, not CT scans, but CT scans can catch things that we usually follow up with an ultrasound. There are tumor markers that we can use to assess the risk of an ovarian mass. It doesn't tell us 100% benign or cancer, but it can tell us a risk. Doing routine tumor markers and ultrasounds is not recommended in an average risk patient because there are a lot of false positives. A false positive is where something shows up abnormal. We get scared, we think it's something, then we go in and remove the ovary or remove something else, and it was actually benign. So in patients who are positive for genes like BRCA, BRCA, or in patients who have other risk factors for ovarian cancer, we can do annual screening with ultrasounds and tumor markers, which is a lab test. But again, it would depend on a person's specific risk factors. But I think there is a lot of upcoming research probably in the next decade or two that we will be able to detect cancer earlier of the ovary based on lab work.
All right, and I know we are coming up on time, but I have just a couple more questions here. How long can you keep an IUD in for?
Well, a couple years ago, I removed an IUD from a woman who had had it since 1974. She came in for some unrelated reason to the hospital, and she had sepsis, and she got a CT scan, and they saw an IUD on the CT scan, and so they called me, and I went down and talked to her, and this was totally unrelated. I said, when did you get that IUD? She said, some doctor in Youngstown in the 70s. So I said, do you want me to remove it? She said, sure. So I looked in, you could see the strings, I removed it, and everything was fine. I would not recommend that. But I don't know, I always have a good story. So of the different IUDs, so the Paragard IUD, copper-based, is good for 10 years. The Kylena IUD, progesterone-based, is good for 5. The Mirena IUD is good for 8 years for contraception. It also has the FDA indication for heavy bleeding control because it lightens periods for 5 years. So do not leave an IUD in longer than what is recommended, please. But that is the maximum time.
Okay, and are sleep issues common with menopause?
Yes. So usually it is a result of disrupted sleep due to waking up from hot flashes at night. Even in the absence of hot flashes, the brain does not like drastic estrogen changes, so it can disrupt sleep cycles, etc. So treatment for that can include hormonal and non-hormonal treatments. So estrogen as a treatment for menopausal symptoms is not your only option. There's non-hormonal options too. So if you don't want to accept the risks of estrogen, or you aren't a candidate for estrogen, there are other options that may be safer for you and may work. So don't be afraid to bring that up.
Do we have any final questions out there? Anybody have anything they're thinking about before we conclude our evening? Yes.
What about uterine cancer?
So screening for uterine cancer usually is done only based on discussion with a patient. So the number one symptom of uterine cancer is postmenopausal bleeding. Uterine cancer is typically, now there are different types of uterine cancer, but the most common one is slow growing and will present itself with postmenopausal bleeding. So that should never be ignored. So bleeding after menopause should always be worked up. You can have bleeding from menopause or after menopause come out of the vagina. It could be coming from the vaginal wall. It could be coming from the cervix. It could be coming from the uterus. So we have to do an exam to figure out where's the bleeding coming from. If you have bleeding after menopause and we can't identify a source vaginally or from the cervix, we would do an ultrasound looking at the lining of the uterus. After menopause, the lining of the uterus should be less than 5 millimeters in thickness, so you're looking at half a centimeter. If it's less than 5 millimeters, we can take an approach of watch and wait because it is very low likelihood to be cancer, or do a biopsy. If it is greater than 4 millimeters, we always do a biopsy, and that tissue sample is sent off to the lab. People can be at increased risk of uterine cancer based on their family history, personal history, or other genetic conditions like Lynch syndrome. So that would be dependent on, again, risk factors and symptoms. Did that answer your question a little bit? Yes? Okay.
One final, another, I'm so sorry. Well, go ahead. You go ahead. I have one more on the chat as well.
You want to go ahead?
Okay. Do Kegels really work?
If they're done correctly. So, oftentimes people say, is the Kegel the end-all be-all? And the answer is sometimes. It's important that you're able to contract the pelvic floor, but sometimes it's a timing issue. I have patients that come in all the time that I test them and they have a strong pelvic floor, yet they still leak. So maybe, again, it's the task, the timing, and we work on that as well. But Kegels really do work if you know when and how to do them. And we also need the pelvic floor to be able to contract involuntarily, and often it doesn't if it's weak.
Okay.
So.
Thank you.
Okay, my question is, we had 6 girls in the family, but 3 of my sisters, one with cervical cancer, one with uterine cancer, one with ovarian cancer. The ovarian cancer one, she didn't find out she had that until she was 72. And I'm wondering how that runs, like, how am I going to be worried about that? Because I haven't had other testing done.
Right. So although they're located very closely, uterine, cervical, and ovarian cancer in general are not related to each other. So a family that has ovarian cancer in their family is not particularly increased risk for cervical cancer or uterine cancer, or one versus the other. So cervical cancer in most cases is environmental, related to the HPV virus, which is acquired through sex. So I think for cervical cancer, I would talk with your doctor about your specific history with pap smears and screenings. Uterine cancer, again, we would have to kind of delve into how old your sister was, what her risk factors were, what kind of uterine cancer she had. Now with ovarian cancer, so usually in someone who has ovarian cancer, is your sister still living? No. Okay, I'm sorry. Okay. So if someone in your family has cancer, I highly recommend having them tested for a panel of genetic mutations to see if they are a carrier. If they would be a carrier of a mutation, then I would recommend testing all first-degree relatives, which would include you. Now, you'd have to do a family tree, and you can do this at your OBGYN's or a genetic counselor's office, but do a complete family tree to determine Was there other, usually ovarian cancer is more associated with breast cancer. So is there a trend of breast cancers and ovarian cancers in the family? No. And then looking at the age. So one relative after menopause who had ovarian cancer, it is not suggestive of a genetic mutation, but your risk may be increased slightly. I don't think it would be increased to the point where you would want to do that annual screening with the ultrasound and blood work. But if you wanted to, you could always do the genetic carrier cancer screening just to make sure you aren't a BRCA carrier. It does not sound like that it runs in your family. You could do that if you would be a carrier. I would recommend annual screening. If not, I would just recommend going and getting your annual pelvic exam. Yeah. Mm-hmm. I don't know what the U.S. Preventative Services Task Force says. I recommend continuing screening if you think that the benefits outweigh the risks. So if someone is 100 years old and very healthy, and if they had breast cancer, they would treat it, I would get a mammogram. We're living longer. I mean, what are we going to cut it off at 70 or 80? I mean, what's the cutoff? I can't remember what the exact cutoff is per the U.S. Preventative Services Task Force. But if you think that you would treat if you had breast cancer, I would get a mammogram. The American College of OBGYNs and American Cancer Society recommends every year. The U.S. Preventative Services Task Force recommends every 2 years. So it's whatever organization you subscribe to. I subscribe to yearly. Yeah. Mm-hmm.
Are there any other questions floating around?
When an older person, say 70 plus, is there some kind of screening or test just to see like what your hormones are doing or some levels?
So we have hundreds, if not thousands, of hormones in our body. There's no screening test. If there's nothing wrong, I wouldn't order a test. But if you have specific symptoms, I would gauge it towards those symptoms. I can tell someone if you're 70 years old plus and not taking hormone replacement therapy, your estrogen levels will be extremely low. And we know that. And that's not abnormal for someone in their 70s. But if someone is 55 and postmenopausal and having hot flashes, we would treat that. So lab work serves a purpose in some senses, and in other senses, we don't use it as our threshold to treat, if that makes sense.
I know we had a question at the table right behind too.
Mm-hmm. It depends on the way that your tubes were occluded. So tubes can be burned, clipped, or removed. If they're clipped or burned, the chance of getting pregnant after that is 1 in 250. And it's because they can recannulize or the clip can fall off. If they remove your tubes, the chance of that is less likely. I will never, ever tell someone they cannot get pregnant because I have seen someone pregnant without a uterus. Catch me after and I'll tell you how. But that was a 1 in a billion chance. But just if someone says, oh, I have my tubes tied, I could never get pregnant, never say never. But I recommend complete salpingectomy, which is removing the tubes rather than clipping or burning, because ovarian cancer has actually been shown in some cases to start in the end of the fallopian tube, the fimbria. And in women who have their fallopian tubes completely removed, their risk of ovarian cancer goes down. So it's actually standard practice now, rather than burning or clipping someone's tubes, we actually just remove them completely. Talk to your doctor or get the operative report. Mm-hmm.
In the back?
For the mammogram, there's the 3D. What do you prefer to think people should get?
Mm-hmm. Do you want to talk on that?
Regular or the 3D? I just get the regular.
First of all, you need to know if your insurance will cover the 3D. The 3D has a better quality picture. So most physicians will order it that way if where you're going offers it. Yeah, we have that.
Okay. So I think We should give a big round of applause for our entire panel. Thank you so much for staying a little over time here. Thank you for all of your expertise. If anyone has any other questions that haven't been answered tonight, you have a survey on your table. Please fill out the survey regardless of whether or not you have another question, but if you have a question, feel free to write it on that survey. If you would like to leave us an email address, please leave that email address, a phone number, some way that we can get back in touch with you, and we'll try to get that question answered. Be on the lookout for our Facebook video will end up going up. We've recorded, and it will be on Facebook at some point if you'd like to replay this. And is there anyone who does not have a raffle ticket? Because we're going to be drawing numbers here shortly. Do you need a ticket? Jen, can you pull one more ticket here?
She's an employee. She's a nurse badge.
And as soon as that one's filled out, we can draw some numbers. You don't need to fill it out. You should, that's your like coupon ticket. So we have the other half of the ticket, which will have the number on it. We're going to call it by number. And we are going to raffle off in the panel. Thank you again so much. One last round of applause. I know it's late, so if you all need to leave, please feel free. We're going to pull our raffle and then let everyone, intermingle.